Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Respiratory Issues in the Older Adult, Episode 4, Pulmonary Emboli. After viewing this episode, participants will learn about the epidemiology and pathophysiology of pulmonary emboli. Participants will review the abnormal physical exam findings and symptoms seen in geriatric patients with pulmonary emboli. Finally, participants will review treatments for pulmonary emboli in the field.
A pulmonary embolism is, in essence, an obstruction of the pulmonary artery with some material that originates from elsewhere. That material is typically a clot, and that clot typically originates from the deep venous system of the lower abdomen, the pelvis, or the legs. But it can be other material too, although rarely. It can be tumor, it can be air, it can be fat that embolizes from elsewhere in the body. The pathophysiology of the pulmonary embolism is complex. First and foremost, you're obstructing the pulmonary artery, and therefore there is a region of the lung that isn't participating in gas exchange normally. But the thing about the pulmonary embolism that can actually kill you is that there is a lot of inflammatory changes that go on when this clot travels to the lung, which makes the region of the lung work less well, and it can also put a lot of strain on the right side of the heart and can make that not function very well. So all of these things combined can make this truly a critical illness in some people.
A pulmonary embolism is a blockage of the pulmonary artery and reduction of blood flow to the lungs. Blockage could be caused by a variety of substances and originate from various parts of the body.
Pulmonary emboli in the geriatric population is very common, although we certainly don't know how common it is, partly because we know that probably only half of all pulmonary emboli are actually diagnosed, at least while the patient is living. So it's common, although we really don't have a good understanding about how common it is.
Geriatric patients are more likely to develop a pulmonary embolism. Part of it is they tend to have increased risk factors. There's an increase in inflammatory markers that are associated with aging, and those tend to increase clotting factors.
There are a lot of risk factors for development of pulmonary embolism, and they typically accrue in the same situations in which clots develop, especially in the lower legs. These are things like being immobilized or bedbound for any period of time, recent surgery, which often contributes to people being bedbound, prolonged travel can do this. There are a host of other things that can increase the likelihood of clot development, cigarette smoking, obesity. There are certain inherited and acquired states which makes the blood more likely to clot. Cancer is one of those things which tends to make the blood more likely to clot. High blood pressure, a recent stroke, some part of your body being paralyzed. These are all things that can promote clots. And any clots that develop in your deep veins of your pelvis or your legs put you at high risk for a clot to travel to the lungs.
Older adults tend to have more risk factors for PE. Risk factors for PE include age, cancer, history of blood clots, fractures, heart attacks, surgery, inactivity, trauma or burns, stroke, birth control, estrogen therapy, and increased clotting factors.
The signs and symptoms of pulmonary embolism are rather nonspecific. The most common symptoms are shortness of breath, typically acute in onset, cough. About a third of people will cough, and it's common for people to have some pleuritic chest pain, meaning they have pain in their chest when they take a deep breath. Some of the signs are again very nonspecific. People can be tachypnic, meaning breathing quickly. You can find low oxygen levels without a more rational explanation for why that person would have low oxygen levels. There can be a heart rate response. They are often tachycardic. And they can have rails on their lung exam. But all these things, again, are not specific for the diagnosis of pulmonary embolism, but they are things that can help clue you into the fact that this person might have had a clot travel through their lungs. Other things that are meaningful are whether they have leg symptoms. Do they have either symptoms of calf or lower leg pain? And can you identify any lower extremity swelling or redness that would lead you to believe that that person might have a clot in their lower extremities?
Once again, geriatric patients tend to have more blunting of their symptoms, so they might not have as much pain associated in the costal region from their pulmonary embolism. They may be, though, more short of breath with pulmonary embolism because of decreased pulmonary reserves. I would examine their legs and look for differential swelling in their lower extremities, which can be a sign of a DVT, which predisposes to a pulmonary embolism. You may find just shortness of breath without increased lung findings. You may find splinting on one side due to pain with respiration, and they may present with mental status changes more commonly than the younger population with a pulmonary embolism.
It's very difficult to recognize a pulmonary embolism in the EMS setting. In fact, it can be challenged to recognize a pulmonary embolism in the hospital setting. All the things, all the symptoms, and all the signs are non-specific, and you can see them both in PE and in a host of disorders that are not pulmonary embolism. And so basically the best way to diagnose a pulmonary embolism is first to suspect it for a host of reasons. And number two, you have to look for it. And we look for it by either doing a fancy scan of the lung. Sometimes we look for certain clots in the legs with ultrasounds. And there are additional both laboratory and radiologic studies that are done. But it's very difficult to diagnose a PE, and it would be pretty challenging to ever make a convincing diagnosis without the studies that we have available to us in the hospital.
Symptoms of PE are nonspecific, meaning they are common symptoms found in other disorders in addition to PE. Older adults can present with blunting of symptoms and present with less severe complaints than a younger individual. Symptoms include dyspnea, tachypnea, chest pain, and cough.
The pulmonary embolism is treated primarily with anticoagulation, meaning medicines that are either given in the vein or by mouth to prevent the blood from making further clots, which can be continued for short or long intervals after the diagnosis of PE is made. So that's basically the foundation of care. There's a lot of additional supportive measures that we do. In rare cases, people get thrombolytics, meaning clot busting drugs. On rare occasion, there are some procedures that can be done to broken up the clot, and there's also surgery that is done very rarely to remove the clot itself. But the foundation of care is going to be the anticoagulation and a lot of other supportive measures, which include oxygen, and sometimes we help support the heart and blood pressure with medicine. And occasionally we have to take over the breathing with mechanical ventilation, but all those things are going to be supportive in nature.
Field treatment for PE is limited. PE is diagnosed and treated in a hospital setting primarily with anticoagulants. EMS should complete a thorough medical history and physical exam. EMS should rule out other conditions like myocardial infarction. This includes performing a 12-lead EKG and gaining vascular access. After viewing this episode, participants will learn about the epidemiology and pathophysiology of pulmonary emboli. Participants will review the abnormal physical exam findings and symptoms seen in geriatric patients with pulmonary emboli. Finally, participants will review treatments for pulmonary emboli in the field.